Let's go ahead and get started. Friends and neighbors, let's go ahead and get started. I'm Rick Miles. I lead the Senior Geeks Club here at Hilltop. Jim Brandt couldn't make it tonight. He had knee replacement surgery, as most of you know. So he said he was putting his leg up. He's doing very well, but he had it 2 or 3 weeks ago, and it was bothering him today, so he had to ice it up. And so he won't be here today. But I'm happy I'm here, because last year I was in the hospital. So maybe we're trading off. I don't know.
This guy's bad luck.
Bad luck. Yeah, bad luck. I have to schedule this in a different time here. Yeah. So we're going to hear this wonderful lecture. We had these two speakers out here last year, and great attendance, and some of you may have heard them, and I'm sure they're going to bring us more information, new information, and just to refresh our memories, because I don't remember, what happened last year. Probably you didn't either. Yesterday. So it's my pleasure to introduce Dr. Drs Motz. He's a highly respected orthopedic surgeon. He's born and raised in Colorado. He is now a pickleball player.
Since last year.
Yeah. He's been in private practice since 1994, and he's established himself as one of the most trusted and sought-after surgeons in the region. I've heard many good things from all of you about him too. Over the course of his career, he's worked with numerous professional sports teams, including the Colorado Rockies, Colorado Rapids, Denver Grizzlies, and in addition to this, he has an impressive resume in sports medicine. He deals with people like us in our sports injuries and how to treat them and prevent them. Now, in addition to Dr. Motz, we have a second speaker tonight, Dr. Kelly Thornton, and she's a highly skilled physical therapist from Colorado, and with a doctorate from the University of Colorado.
Great.
Are you a pickleball player too?
I haven't tried yet, but my husband wants to play.
Oh,
so.
really?
I don't know, I'm scared. I've seen too many injuries.
Yeah. You're young enough. Dr. Thornton has extensive experience working with athletes of all levels, like all of us, ranging from high school to professional, and she has a particular interest in orthopedic injuries and post-surgical rehabilitation. Please join me in welcoming Dr. Motz.
Thank you. So, for those of you who were here last year, you're going to see a lot of the same things because the injuries haven't really changed very much. But one of the things I found out last year after doing this is I went through my part of it, and then Kelly came and talked about some of the things that you can do to prevent injuries, and all of the fascination seemed with that. So I'm going to go through my part a little quicker, and we're going to spend a little more time with Kelly's side of it to try and keep you from being in the operating room, which is a theme of my talk. Is a lot of this is about prevention. It's trying to avoid going into my world in the operating room and try and stay on the pickleball courts, because it is happening out there. As you may or may not know, pickleball was named by the wife of one of the inventors, and it was because it mixed a bunch of different elements, and at the pickle boats at regattas were people just thrown together, and she thought this was thrown together from a lot of different sports, so that's where that came from. This is the fastest growing sport in all demographics in the United States, growing even faster. These statistics are old from 2020. It's getting bigger and bigger all the time. It's bigger in all age groups. Considered to be a little bit less demanding, but we do see a lot of injuries. I see a lot of people with this and with injuries from this. So you do have to be a little careful, and that's the key to this tonight, is to try and do things to try and keep from ending up with an injury. all of these injuries, whether it's upper extremity or lower extremity injuries or spinal injuries, can be acute injuries and they can be chronic just from overuse injuries. The common ones in the lower extremities are meniscal cartilage tears, quad and patellar tendon ruptures or tendonitis, ankle sprains, calf strains, and Achilles tendonitis or ruptures. Upper extremity injuries, things people most worry about are rotator cuff tears, of course, but tennis elbow and golfer's elbow are very common, wrist sprains and wrist fractures. So those are the things that I'm gonna run through with you tonight. The meniscus is the pad that sits in between the thigh and the shin. It's also, when you hear about people saying they tore their cartilage, it's the meniscal cartilage they're talking about. There's two kinds of cartilage in the knee. There's articular cartilage, which is the surface cartilage. So if you eat chicken, it's the shiny white on the end of a drumstick. You have that, hopefully. When it wears out, that's when you end up having to have a knee replacement. So that's one type of cartilage, but the kind of cartilage we're talking about are the pads, and there's two of them, one on the inside of the knee, one on the outside of the knee. So medial is inside, lateral is outside, and these usually occur with twisting injuries, which happens frequently on the pickleball court. Last year when I gave this talk, I had went out and watched pickleball because I had never even seen it, so I wanted to go out and see it. I went and watched a professional tournament. This year I actually did start playing. I went down and visited a friend in Key West, and his goal while he was down there was to learn how to play pickleball, so he dragged me out on the court too. I found some of these injuries as I did that. Some of these things really did get to me, so I really want to hear more about Kelly's talk because I need some of that too. So these are usually twisting and pivoting type of injuries. You usually, if you tear your meniscus, you'll usually have pain right away. You usually will have swelling in the knee. That's other than pain, the most common thing is it's a knee that swells up. So if you're getting swelling in your knee and pain along either the inside or outside or both, you might have a meniscal tear. They're very easily diagnosed with MRIs. Most of them in adults are on the inner rim of the meniscus. You can see up there, that's the two of them kind of looking on the top of the shin. But they're in that inner area there, and so when they tear in that zone, there's no blood supply to that part of the meniscus. And so that's where they tear most frequently in adults. In teenagers and adolescents, they're more common out in that red area, what we call the red zone, where there's good blood supply. And in that area, they're repairable. But they're repairable in adults in that area too. So if you get a tear in that area, they are potentially repairable. They just don't happen very often, so you don't hear about it very much in our age group, because most of the time we're just going to trim out that cartilage. But if we can repair them, we'd always prefer to repair them because they really are pads. They do protect those surfaces, and if you remove that meniscal cartilage, there's a direct relationship between how much cartilage you remove and how much you increase your risk of developing arthritis over time. So in the 30s and 40s, they thought the meniscus was an aberrant structure, and if you had knee surgery or tore your cartilage, they just took the whole thing out because they didn't think it was such a good idea. And so that was all the early people in the 60s and 70s who got all the early knee replacements, were all the people who had their meniscus removed because they all developed arthritis in their knee afterwards. So most of the time, if you do tear your cartilage, it's usually going to be treated surgically. Some people have small enough tears and they don't have the loose flaps. They have just a little split in it that they can tolerate it. But if you have a tear like this one where you see that big flap of loose cartilage, that knee joint is made to fit together perfectly with that meniscus filling the space in there. And so when it gets out of place, it's very painful. And if you think about what it's like walking with a pebble in your shoe, now you're getting something that's in between those two bones that have good blood supply, good nerve supply, so it's very painful to walk on that. And that's why those usually end up getting treated surgically. It's done arthroscopically. The question that's in everybody's mind is, how fast can I play pickleball after this? And the answer is you can do it as soon as you feel like it, but realistically it would take you at least 4 to 6 weeks after a knee scope for a meniscus to be back feeling like you'd want to play. That's kind of the soonest I would expect. But if you came in and you had your meniscus removed and you came in for your post-op check in 10 days and said, I'm going to go play tomorrow, I'd say you're going to be sore, but it's not dangerous. So you can do it as soon as you feel like it. All right, patellar and quadriceps, The meniscus is hard to prevent. It's a pivoting injury. The meniscus gets stiffer as we age, and they'll tear sometimes just turning a corner hard, so they're kind of hard to prevent. These are very preventable injuries. The quadricep tendon, the four muscles of the quadricep come together and they form a tendon that envelops your kneecap. So we talk about the quad tendon as the portion up above the kneecap and the patellar tendon is the portion below, but it's really all one structure with the kneecap sitting in the middle of that. So there's four muscles that make up that, which is why it's the quadricep. And then the tendon attaches down at the upper part of the shin. The injuries occur almost always when you have quad tendon ruptures or patellar tendon ruptures. They occur in the face of tendonitis. Almost everybody who has a quad tendon or a patellar tendon rupture has tendonitis. So if you don't ignore that and you get on a stretching program or come in and see Kelly and start doing some therapy to try and prevent this from becoming a quad tendon injury, you're going to do yourself a big favor, because these are very, very long recoveries. These are usually an acute injury, you know right away. Most people feel a big pop in their knee. There's usually quite a bit of deformity because that tendon pulls back. The kneecap is now floating free. That picture up above is somebody putting their finger through the defect where the tendon should be, and that's right through the skin. And you can feel, you can push right down to the femur when that occurs. And you can see down there on the lower right what that tendon looks like, and it's usually very disruptive. It'll tear the entire capsule, the entire sac of the joint when that occurs. So it's a pretty traumatic injury. You aren't able to lift your leg up, so if you hurt yourself, you're not sure, and you can't lift your leg up off the ground, there's a likely that that's what it's going to be. And again, almost 95% of people who have these tendon ruptures have a history of tendonitis. These always are treated surgically. There's just not a very good answer for these injuries if you don't fix them. The tendon continues to pull that apart, so they just don't heal. You have to sew them together. Sometimes we have to supplement them with graft, and this is usually a year to get back to playing pickleball. It's a long haul. All right, ankle sprains. When most people talk about an ankle sprain, they're talking about where they roll their ankle and they injure the ligaments on the outside. So this is the fibula bone on the outside, and there's three ligaments: the anterior talofibular ligament, the calcaneofibular ligament, and the posterior. And the one that's typically injured in ankle sprains is the anterior talofibular ligament, with this one being next. I've only seen one person who ever tore that posterior talofibular ligament, and he tore everything off the end of his fibula. But most of the time, even in complete tears of those ligaments, they're completely detached or completely separated, they still heal 95% of the time without surgery. So most of the time we'll put people in one of the removable boots so they're immobilized to give it the best shot at healing. But really, kind of, even if you ignore it and just go about your business, they still heal in a really high percentage of the time. But if you're unstable, so if you come into me and you've rolled your ankle and you're not unstable when I examine you, I would tell you you can wear a brace, you can wear a splint, you can do things when you feel like it. If you're unstable, I'll usually put you in one of the removable casts because you have a better shot at getting that ligament to heal that way. But very infrequently does that result in surgery. If it doesn't heal and you do have residual instability, it's a really reliable surgery to put that back. We put sutures right into the bone, pull the ligament right back and attach it. You have to spend 6 weeks in the boot afterwards, 6 weeks visiting Kelly with physical therapy, but usually 12 weeks after that surgery, you can be back on the court playing and doing whatever you want to do. It's really a good surgery, but one you want to avoid if you can, like all of these. So surgery only if it remains unstable. There are a lot of other things that really represent ankle sprains, but those are the more typical ones, is the ligament injury. Calf strains are when you injure the muscle of your calf, and these occur from sudden stops, which happen a lot in pickleball. You get that sudden stop and the muscle fires and it fails, and these are really painful, but usually you can push your foot down when they occur, so you're able to still, what we call plantar flex your foot, which is pushing it down towards the ground. So it doesn't keep you from doing that. What really hurts is when you pull your foot up and stretch that tear, it hurts. Most people feel like somebody kicked them in the calf. When that happens, it's very painful. It's painful to walk on it, And again, I'll usually put people in a boot just to make it more comfortable for them to walk. But these heal very well. You'll get stiff, you'll probably need to see the therapist to get stretched out, but these usually heal very well. And they can take up to 12 weeks before they're feeling good enough for you to go out and play. Achilles tendon tears are devastating for pickleball players. There's 3 muscles that make up the Achilles tendon, but usually that's mainly the soleus and the gastrocnemius muscles that are involved. That tendon, this one really does feel, patients come in and say either they got kicked in the heel or they feel like someone shot them in the heel. It's very traumatic. That tendon is big. You'll see on the pictures here, it's a very big tendon, and when it fails, most people know something happened. And it's very painful, difficult to walk. You usually can't push your toe down. You usually can't go up on your toes at all. And again, most people have tendonitis, so if you treat the tendonitis and avoid this tendon rupture, you're gonna be very happy. Traditionally, we used to treat people in casts with their toes pointed down for a long period of time, and they almost always lost motion and almost always were left with weakness. So these are almost always treated surgically now. It's just a much quicker recovery. I usually don't even put people in a cast. I put them in one of the removable boots so they can start walking on it right away, and it's a much better recovery. But it still takes 12 weeks for that tendon to heal, and usually another 6 months or so to recover, to get back at it. That's what that tendon can look like. Most of the time, the ends of it look like a mop. The ends are just shredded. So what I have to do is just clean up those ends first to get good, healthy ends, and then sew them back together. And sometimes we do have to keep people with their toes down for a little while because they've lost enough tendon tissue, but most of the time I can get it flat afterwards. So here you see the size of that tendon. It's big. This is the thumb of the surgeon here, so it's almost as big as the thumb. So now we've had to pull those two. They've cleaned up all the mop ends here. You have to pull those two together, and this is a sewn together tendon afterwards. This is that third tendon we talked about, the fine teres. They call that the intern's nerve. A lot of people think that's a nerve when they're doing these surgeries in the early parts of their training, but that's actually that third part of that tendon. All right, onto the upper side. This is the one that everybody dreads, the dreaded rotator cuff tear. The rotator cuff is, again, most of the time, it's an injury that occurs over a period of time. It's somebody who starts injury, they get inflammation, they're flared up, they're sore, but they want to play pickleball, so they keep playing. They don't go see Kelly. Eventually that tendon is gonna fail. There's 4 parts of the rotator cuff. There's a muscle or tendon in the front of the shoulder, so it's called the subscapularis. There's one on the top called the supraspinatus, and then there's 2 in the back, the infraspinatus and the teres minor. The one 95% of the time that's going to tear is the one up on top, but we do see some subscapularis tears, and then big tears, sometimes they extend into the muscles in the back. But it's all 4 of them. Their job is to keep the ball centered in the socket. They're not big muscles. You might have really big deltoid and pec and biceps that are moving your shoulder around. These are fine control muscles. They're just keeping that ball centered in the socket while all those other muscles are moving. But if they fail, they're very painful. So prevention is possible. If you keep your rotator cuff strong, which we're going to talk some about tonight, that helps you more than anything. So if you get on a good exercise program, anybody who's playing racket sports should be doing at least a couple days a week of rotator cuff strengthening exercises. And really, even if you're not playing racket sports, when you get into our age category, you're much better off if you're doing some regular rotator cuff strengthening exercises. This is a really common problem we see. If you seek treatment early while it's still tendonitis, we can usually calm these down and get you back. It may involve taking some anti-inflammatory medicines. We frequently will try steroid injections to try and get rid of that inflammation, and then get in and get stretched and get strong, and usually you can avoid this becoming a bigger and bigger problem. And that's, I guarantee you'll be much happier if you spend that time beforehand, because the tears are a long recovery. They're usually diagnosed by MRI, although you can usually tell clinically because people are weak and have a lot of pain. And these almost always require surgical treatment because they tend to get bigger and bigger over time. Just like we were talking about with the quad tendon, every time that muscle fires, that tendon pulls away. So even if we have that tendon sitting right where it should, every time you fire the muscle, it does that. So they just don't tend to heal. As they go on, they get bigger and bigger and bigger, and what happens is that tendon on the top of the ball, its job is to keep the ball down in the socket. So as that tendon starts to fail, that ball starts riding up out of the socket. And pretty soon, rather than articulating the ball on the socket, the ball starts articulating on this bone here, which is called the acromion, and then you start getting really significant arthritis. And then we're talking about shoulder replacement instead of rotator cuff reconstruction. So again, don't ignore these injuries. That's kind of what the tear looks like. If you're looking straight down on the shoulder here, there usually are an area of the tendon right near the attachment site. That's an area where the blood supply isn't as good, so they tend to fail there. The acromion bone that makes the roof of your shoulder sits right on top of it, so that's usually the area that we see the tears. The surgery can be done arthroscopically or through a small incision. If you look at the statistics across the country, the healing rate is quite a bit higher making a small incision, so I do, but a lot of my partners will do these completely arthroscopically. The recovery is actually a little quicker if you make a small incision, because since the healing rate's not as high, they usually will keep you in a sling and keep you still a little longer. I usually start people doing physical therapy at 2 weeks. If you get them done arthroscopically, they'll usually wait 6 weeks to start therapy. But both of them have high satisfaction, but still not great. It's only about 85% of people who have rotator cuff reconstructions either way that are happy with how it turns out. So again, prevention is key. Try and keep from getting to that point. The tendon takes 12 weeks to heal after the surgery, and then it takes usually at least another 1 to 3 months to get your strength back to the point where I would tell you, okay, it's okay to go out and start hitting. So it can be 6 months for me to tell you you're okay to go play, and almost everybody who's honest with you, who's been through this, will tell you, yeah, he told me I could play at 6 months, but I didn't really feel normal playing until a year. It's a long recovery. So this is the undersurface of the rotator cuff we're looking at on the left side, which is an inflamed but normal tendon, and then on the right you see the big defect in that tendon up on top. So that's what the rotator cuff tear looks like. This is what the repairs end up looking like. You put stitches in that end of the tendon, pull it over and attach that down. We scrape the bone to create a nice healing bed so that the tendon will heal back to the bone, but that's what an arthroscopic repair looks like. All right, elbow. Tennis elbow is an inflammation of the tendons that attach, and we usually think about tennis elbow as the tendons on the outside, golfer's elbow on the tendons on the inside. But racket sports, you can get either one because it's just the difference of a forehand or a backhand, which one is going to get more irritated. This again is a really preventable injury. It starts out as inflammation. You're going to have pain right over that bony prominence. It feels like a bruise when you touch it, but it almost always will get better if you do some stretching, take some anti-inflammatory medicines, sometimes some injections. These are tendon injuries that can really recover without surgical treatment. But just like those other tendons, chronic inflammation leads to tears. What you see under a microscope with an inflamed tendon is little micro tears. And if you ignore it and let it just keep getting worse and worse and worse, some of those micro tears start lining up into macro tears, and that's when we see defects in the tendons. And once that occurs, that tendon's going to continue to pull away, and it's hard to ever get that to heal. But if you treat them right early on, do some cross-friction massage to keep the scar from sticking down there, maybe do some injections, see Kelly to get some stretches. Usually you can get this better without surgical treatment. But once the tendon tears, it's usually going to be treated surgically. That is an unusual procedure. We do it a little bit more now than when I started, because when I started, the treatment was scrape the bone, have the tendon lay there, keep them still for 6 weeks and hope that it healed. And it was probably about a 75% healing rate. And if you kept somebody still, elbows are really sensitive to immobility. So if you keep somebody still for 6 weeks with even a minor elbow injury, they're usually not going to get their arms straight. Most professional baseball pitchers can't get their arms straight, so it's not the end of the world athletically that you can't straighten your arm, but obviously we want you to be able to get your arms straight. So we don't want to keep you still for any period of time. So now with the surgery, we can get people moving right away. They don't usually lose their motion. Wrist sprains usually occur from a fall. You'll see sometimes some injury to the wrist from hitting the ball, but most of the time that's going to be from a fall. you injure the ligaments around the wrist, which you can see can be multiple. They're very complex. Most of the time, these are diagnosed by just having pain in the wrist, but sometimes it's a little tricky, and sometimes we'll actually see the bone shift on x-rays because there's complete tearing of those, and that will usually result in surgery if that occurs. But most of these are going to heal with periods of immobility. Falling on an outstretched arm, most of the time people will come in, have a wrist sprain, and it really is truly a ligament injury, but there is a bone in the wrist called the scaphoid or the carpal navicular. It's what's called the snuff box. It's right at the base there, and people fall and they think they sprained their wrist, and they actually broke that bone. And it's got really horrible blood supply, so it's very tough to get it to heal. And a lot of people think they sprain their wrist and it just doesn't get better, They come and see us and the bone is dead. And sometimes that ends up in surgery to fix that, and sometimes it ends up in wrist fusions because the bone is so far gone that there's not much to it. So if you have a wrist sprain that's not getting better, go in and get it checked. Wrist fractures, again, usually occur from falls. They're difficult injuries. They do much better now. Almost always a fracture like this is going to get treated surgically now. When I started my training, we hardly ever operated on wrist fractures. Now I would tell you 90% of these are treated surgically, which is bad. You don't really want to have surgery on it, but people do much better. They have much less arthritis. They have much less stiffness. They tend to recover quicker. So if you go in and you have a broken wrist and they tell you you're going to have surgery, you're actually probably going to do better than if you would cast that for 8 weeks or 12 weeks, whatever it takes to get it to heal, because usually you're going to have some residual deformity if you do that. All right. So as I said at the beginning, one of the things we found last year is that Kelly came and did just kind of a brief presentation on ways to prevent this, and as you can see from the top, prevention is one of the big keys here. So she's going to spend a little more time tonight talking about some exercises you can do as a part of a workout program, and also some pre-game stretching that you can do to get yourself in a better position. Yes?
Could you make a comment on plantar fasciitis?
Sure. So plantar fasciitis is, the plantar fascia is a band. I'm going to go back one of the heel pictures here. Okay. So the plantar fascia is a soft tissue band. So it comes off of the front edge of the calcaneus, the heel, and it goes out and it interdigitates into the soft tissues on the base of the foot. So if you think about the arch of the foot is bony, and this string, this is like a bow and arrow. So the wooden bow is the bones, and the plantar fascia is the string. So when you're walking, you're constantly stressing that plantar fascia. And true to the theme of the night, what we see is little micro tearing here. And so what you notice with plantar fasciitis is, especially first thing in the morning, you get up and you take those first couple steps, and it just aches and hurts right in the bottom of your heel. And you take a few steps and it loosens up a little, never really goes away, but gets a little better. You sit for a period of time, you go have coffee, you sit for an hour, you get up and it starts all over again, and it's just kind of miserable. And it's just like all these other things. If we can stretch the plantar fascia, most of the time we can get this to go away. Kind of the opposite, this one used to be treated surgically a lot. When I was doing my training, a lot of people ended up getting their plantar fascia released. But now, 95+% of people, if you're patient enough, it will get better. But you have to be really diligent about the stretching. So the 3 key stretches for me are what I call a toe stretch, which is just literally grabbing your toes and pulling them back, and you'll feel your plantar fascia stretch when you do that. Even if you don't have plantar fasciitis, you'll feel that. And then I have people take a can that they can put by their bedside, and you just roll over it like a rolling pin, so it kind of reconstitutes that arch to stretch the plantar fascia. And then the other thing you want to do, which Kelly's going to show you, is a good Achilles tendon stretch. Because if your Achilles tendon is tight, you tend to walk up on your ball of your foot a little more, and you stress the plantar fascia more. So you want to make sure that your Achilles tendon is stretched too. If that doesn't work, we'll do injections in there. And I always tell people, this is going to be the most painful injection you've ever had. Most people don't let me do it more than once. Even though it works, most people don't want to do it again. So try and stretch it first. But the injections do help, and most of the time people get better, and very rare that we have to do surgical releases now.
So what are you injecting in most of these things? Cortisone?
Steroids, yeah.
Steroids?
So everybody calls it cortisone, even all the medical community, all the doctors call it cortisone. Nobody uses true cortisone anymore. When I started, we were still using cortisone. Cortisone was really toxic. Some of you probably had cortisone injections when you were younger. Your parents probably told you the nightmares of being injected with cortisone. Cortisone was really toxic to the tissue. People were really sore after cortisone. Now the steroids we use are much less toxic. They get in, they get the inflammation out, they get out of there. So usually, other than in the heel, most of these injections, a little bit for tennis elbow, but like a rotator cuff injection, most of the time those are, you'll feel the needle stick and that's about it. It shouldn't really be painful. If it's really painful, you're probably getting an injection into the tendon itself, and that's what we don't want to do.
What do the Durolane shots do? I mean, the jellies. How's that different than the
Yeah, so for knee arthritis, we sometimes do steroid injections. And what I will tell you with those is they're gonna help, but they're gonna be short-lived because the problem doesn't go away with a steroid injection. All you're doing is getting rid of some of the inflammation. So I tell people this might be good if you're gonna go, you know, you're going on a golf trip with your friends and you want to be able to walk the course for the 4 or 5 days you're on your trip. Do it before you go and it'll help you for that. You're going to go to Europe and you're going to walk around the Spanish Steps or whatever it is, and you want to be comfortable. Steroid injections are good for that. There are some people who get months and months, but most of the time that's a short-term effect because you're just getting rid of inflammation. The viscosupplementation is hyaluronic acid, and hyaluronic acid is a normal product of your joint fluid. And this is a thickened version of that. So it's like a jelly. So your normal joint fluid is more the consistency of water. So when you sit in a chair and listen to a talk like this, all that joint fluid goes off of those damaged surfaces and you get up and you're really stiff and sore as you start walking. As you start moving that joint fluid around, it starts feeling a little better. The pain gets a little bit less. The idea of the Durolane and the Synvisc, and there's now probably 10 different types of it, is it's a thickened gel. And so it stays on those surfaces a little better, so you have less frictional problems with it. You have less stiffness with periods of immobility, including at night. And so it just decreases pain because it decreases friction, decreases inflammation. What we inject is gone 2 or 3 weeks after we put it in there. The effect can last 6 months or more, so we think it stimulates your own joint fluid to be a little more viscous when we do this. But what we put in there is gone pretty quickly, which is a shame since it's $1,400 or whatever. Other questions? All right, Kelly.
All right, thank you. So next, I have lots of stuff to give you guys. I don't know how many of you guys were here last year, but I know you guys are probably really bored of your exercise program because you've been doing them every day and progression, like I'm ready for the next step. So I added on, I did a little bit more. So the first thing we'll go over are stretches, and then I have a bunch of different packets about wrist, shoulder, ankle. We'll go over all of that. So the first packet is a big packet of stretches. So if you guys want to take one, pass it around. I made 50 copies, so I think we should have enough. Okay, cool. Okay. Extras? Okay, I'll put them up here in case anybody needs some. If you guys want to take some to your friends, just skip it out tonight. That guy who always gets hurt. Okay. So first one I have on our sheet is the posterior glenohumeral capsule stretch. So basically you're bringing your arm in front of your body. You should feel a stretch in the back. So this is going to be really good if you're playing pickleball, if you don't warm up and you're really trying to get that ball back in that back corner. If you're not stretched out and you hit that ball pretty hard, you're going to kind of feel it in the back, your rotator cuff. So this is a really good one to do. Now, a lot of people you see out getting ready before they play, you know, they're talking to their friends, but they're just kind of going like this. You want to hold your stretch for at least 30 seconds to really stretch out that muscle tissue. Have you guys done this stretch before? Does this look familiar? Is this new? Okay, good. No, so yes, no. Okay, good. Well, at least new for a couple people. Okay, any questions on that first one? Good. Okay, yes.
And the way to do it that helps me is to kind of pull the shoulder back. as I'm
Yeah,
doing
that works
Is
too.
that
There's
right?
multiple ways, yep, and you can keep your elbow bent, you can have good posture and do it. Sometimes if it's really tight, you can put a tennis ball, some sort of ball, racket ball, in a pillowcase, flip it behind your shoulder, and get up against the wall and kind of massage it against the wall as you stretch. It kind of hurts, but it feels good. So yes, that's another way you can do it for sure. Okay, next is the doorway pec stretch. So I like this for pickleball players. I like it for people that sit at a desk, looking at their computer. If you have this kind of posture and you're sitting like this for a long time, then basically those pecs, your pec muscles in front get really tight. So maybe I'll use this. Oh, that works too. All right, so then just kind of going in the door, you should feel the stretch kind of right in here. So that's a good one. And another thing too, if you're in a doorway, you can put both arms up and lean in. And again, holding for about 30 seconds. That one feels really good. So those are my two favorite shoulder stretches. Next, we'll move on to wrist flexion and extension stretches. So this will stretch your wrist extensors. So if you're having a lot of pain on the outside of the elbow,
Those
this'll
are
help this one.
tennis elbow and golfer's elbow prevention.
Exactly. So holding this way, and then you can also do it this way. You want to make sure the elbow stays straight. Sometimes people bend their elbow and they're not going to get it. Looks like everyone's doing it nicely.
Kelly, can I ask you, are we
Yeah.
doing prevention or treatment?
So, good question. It's both, really. So, let's say you're gonna play a game. I would recommend doing these stretches before a game. If you're like, you know what, I really was hitting the ball hard, my elbow's a little sore, you're gonna wanna do these too. So that's a really good question. Good. And there's different ways you can do it. If you're not feeling a stretch, you can do it on a table. Oh, my right one's tight. You could do it this way, like pray that you win the game. Pray that I don't get hurt. So there's multiple ways, but yes. Okay, next we'll move to the lower extremities. Hamstring stretching. So you probably won't do this at the pickleball court unless you're, I don't know, maybe you guys are really competitive and you want to smear your opponent, like that guy. But basically what you can do, this one's a little easier on the back. It keeps your spine in a neutral position. So grabbing a towel, grabbing a strap, and just putting your leg up in the air. It's this first one on that second page. Some people can do a hamstring stretch by just propping their foot up, like so. Same kind of thing. You can bend down and touch your toes. Sometimes people say that bugs their back, but it also gives you a little spinal mobility, so that's fine too. Again, hold for 30 seconds, and typically I tell people to do about 3 of them. Next is the piriformis stretch. So that's the second one on the second page. People call it the figure 4 stretch. Another good one for sciatica, if you ever have that radiating pain going down the leg. This is a really good one to stretch out your hips.
That's one of the things I noticed when I played pickleball, is I got really tight in my glute and my piriformis.
Yeah, your piriformis is a small muscle like deep underneath the glutes. So yeah, when you stretch, you should feel it kind of deep in the back, like so. And you can even do it sitting. Kind of stand in your camera. So basically putting your leg up like this, leaning forward, like so. That was good. All right. So yeah, you can do it seated, and then there's also a standing one too as well on here. Sometimes people say, I don't feel it this way. So then there's different modifications. Again, laying on your back, seated, standing, all good ways to perform the stretch. Next, standing quad stretch, prevention for quad tendon tears, patellar tendonitis. So if you're having pain above the kneecap, below the kneecap, I see this a lot, especially older population. They tend to have really tight quads. A lot of people that sit at their desk for a long time, it keeps your hips in a shortened position. So what you're doing here is really stretching all of that. So you can hold on to something, stand up tall, and you should feel a stretch in the thigh. If you're not feeling it because you're flexible and you've been doing these, you can bend the other knee and get a little bit more of a stretch. Same thing, this one. It's another way you can do it if you don't have a chair at the pickleball court. But that's another good one. Okay, page 3. So same thing, quad stretch. It's the same thing that I just demonstrate. Maybe when you get out of, like if you're laying in bed and you don't want to get out of bed yet, you can do it right first thing in the morning, get it over with. You got it done. Keep your strap by your bed. And then lastly, it helps with plantar fasciitis, Achilles tendonitis, prevention of Achilles ruptures, the calf stretch. So you can put your hands on a wall, but basically 1 foot behind you, you want your toes nice and straight. And you want to lean forward with the opposite leg until you feel a stretch in the lower leg. So hold there, and then you can switch and do the other side. That was not 30 seconds, I know. Then hold there. Another way you could do it is slightly bend the knee. That'll get more of your soleus that Dr. Motz was talking about. This one will get more gastroc. I feel like this is a pretty common one, so hopefully you guys are already doing that one. I think I showed you on that last year, so you are.
Yeah.
Okay, any questions like stretching? Let's go. Yeah.
Is there anything that you could do, like if you've had, an ankle that rolled and it's still healing?
Okay.
Are there things that you can do, like now to strengthen it, or is that something you're gonna talk about in a
I
few
will talk a
minutes?
little bit about that, but yeah, if you've rolled an ankle and let's say you sprained a ligament, maybe you didn't rupture it, it's stable. Really what you want to do is strengthen all the muscles around to basically stabilize the ankle. I'll go over it, but like some of the things you can do are just standing on one leg, just to get all your muscles activated. Maybe standing and reaching, because if you think about with pickleball, if you're gonna go on your right leg to try to reach for a ball, you've got to have that stability and strength. And not only do you want to strengthen your ankle, you want to make sure your hip is nice and strong too. Because if you do all this rehab on your ankle and you do this, but your hip isn't strong, that's going to give. So keeping the whole leg strong is important. But I'll go over more about the ankle and maybe some extra ones if need be. Alrighty, well let's start with ankle since we were just talking about that. Here's my ankle papers. And here's this. Ankle balls. With some of these, I feel like I give the big stack to the other side. I'll go get some water. Are there extras over here? I feel like I shorted this side of the room. Yep, she needs the stretches. Do you guys need more papers over here? Okay.
Anybody else?
Okay. So then next we'll move on to lower extremity. Now this is all strengthening. Everything we just talked about was a stretch. So not only is it important to have good flexibility, that way when you're doing different movements and pickleball, you have the flexibility, also the strength. Because you're out there for a long time. I've heard some of you guys are doing double headers. You want to have that endurance. Because that's when people get hurt, when the double headers, end of that second, third, fourth game. So we really want to make sure you have the strength. So first one I have on here are heel raises. So holding onto a chair, just going up on your tippy toes as high as you can, putting equal weight through each leg, up and down, 2 sets of 10. Usually we'll do it. If you're really, really strong and say, I don't feel anything, single leg. You can do one at a time. So that's another modification. And that'll get your calf nice and strong. So pretty easy to do. You can do that one at home, pickleball court. Another one, I call them burners because typically you feel the burn, but trying to tap your feet as fast as you can. So if you guys want to try, alternate your feet, go as fast as you can. I feel like I'm not good at it. Going as fast as you can. You kind of feel the burn in the front a little bit. So this will get strength and get you strong in the front of the leg. And it also kind of helps with flexibility, because we talked about having that calf flexibility. If your calf's really tight, it's gonna be really hard to get your toes up. So maybe that's a sign, hey, I should probably stretch my calves, I can't even get my toes up. So that's a good one. Okay, next is a back sport. So here's the back sport here. I've had so many patients that are like, I want to build one of these. So I don't know if any of you guys are crafting, but basically it's a wooden board. You can put like a little round little ball on here, half ball. You can kind of do any sort of shape. But what you can do, maybe if you've had an ankle injury and your ankle's feeling really stiff, kind of moving it around, just to kind of get a little motion. You can get creative and try to balance on it, and that really works. Yeah, fall, exactly. Don't get too brave if you don't feel comfortable with it. I'll give you my business card, no. Or you could mimic it. If you don't have one of those boards, just trying to kind of wobble on your ankle side to side. You could balance and stand on like a yoga mat, a pillow, a couch cushion, and that'll kind of help kick those muscles into high gear. So to answer your question about if your ankle's feeling really weak, those are some good ones you can do. Another one is TheraBand exercises. I brought a TheraBand, I can show you those. I don't have this little sheet, but this kind of gets different muscle groups. So you can, let's see, we'll do this one first. So going this way, can you see? Going this way to get your calf strong. So you can either put your legs over here, you go aside, and going out and in. And the key for this is to have good control. If you're going out and your foot flings in, you're not controlling it. Because sometimes people are like, oh yeah, you're talking to my friend, like that's doing nothing. You want to just make sure you have good control. And this will get the perineal muscles on the outside of the ankle. And then to do the other side, it kind of takes some coordination. Someone could also hold it if you feel like this is too tricky. But now you're going in to get the posterior tibialis. Like that. And then another one is you can have somebody hold it, or you can kind of do this maneuver and go up and down. And that's kind of like the burners we just did, same muscle group in the front there. So kind of an extra ankle strengthening exercise. And I would say like 2 sets of 10 is good for that. But that'll help get your ankle nice and strong. Okay, so that's kind of what I have on the foot and ankle. Do you guys have any questions about those? Okay. Tiffany, all right. Cool, he's on it.
Yeah.
I got an assistant. I like this. What are you doing tomorrow?
I'm expensive though.
Charge her the hourly rate.
She doesn't want to see that.
Just give it a try. Why not? Okay. So kind of like I was saying before, not only do you want your ankles nice and strong, but with pickleball, where you're doing quick motions, you need your whole leg nice and strong too. So the first 3 are probably my favorite exercises. You've maybe seen them before if you've ever been in a PT clinic for a lower extremity injury, but leg raises. So basically, I'll get on the ground, I'll show you. So basically, I don't know if you can see me, but leg on your back, keep your knee straight, up and down. This will get your quad and your hip flexor. 2 sets of 10. Laying on your side. A lot of people cheat and bring their leg forward. That's not going to get the muscle. You want to kind of lean forward, leg back. You want to get your gluteus medius muscle. You'll feel it right here. Lastly, hip extension, going up and down to get your glutes. If you have low back pain, try to lay flat, because arching your back like that will not feel very good. Okay, so those are those. Ooh, wait, one more on the ground. Another favorite, clamshells. So this is kind of like this one. This one's a little bit easier, but basically just bringing that top knee up and down. And this will get your gluteus medius here. This muscle is also largely responsible for single leg balance. So if you ever feel like, gosh, my balance isn't very good because of strength, this is your exercise. Okay, hopefully you guys can kind of see that a little bit.
So you can have your head up the way you had
You
it
can.
down?
You can. All right, next. Four-way hip. I like this a lot. So this is a lot like what I just did, but standing and with a band. So I'm going to loop this little guy here. And what I'm going to have you do, oh, look at this. What a guy.
Kelly, there's all different kinds of strings of TheraBands.
Yes. So TheraBand brand, which is the most common, yellow's the easiest, followed by red, then green, then blue, then black. So I didn't want to embarrass myself by bringing a yellow, and I don't know if I can do a black, so. So there's 4 directions. So basically standing here, going in and out. If you're really good, you try to do it and not let that right leg touch the ground. Some people's balance isn't so good, so that's fine if you have to tap. But it's actually a really big workout for your left leg, the stabilization balance leg. So after you get about 10 to a 10, you rotate 90 degrees, and then you kick forward. That's too much tension. I need to get in the gym. I have a 2-year-old, it's kind of hard to do it these days. And you kick forward. This is gonna get your hip flexor stronger. Keep your knee straight. And then you're gonna kick to the side. Gluteus medius again, that abductor going out away from your body. And then extension. This will get your glutes. Keep your knee straight. This is getting Dr. Motz's biceps. Cool. So if you don't have someone to hold it, you can hook it to a sturdy piece of furniture underneath here, have someone sit there, your bed. You can actually tie it in a knot and put it in a door. Open the door and put it kind of down here and close the door, and it should be fine. So no excuses. You can do this at home without another person. Okay, and then lastly, wall squats. So basically, let me find out so many pretty pictures. So, wait for the camera. Yeah, no excuses, you got it. So going up and down. So this is kind of like a mini squat, and I like it because a lot of times when people squat, they bring their knees over their toes. That's not a good squat, that's hard on the knees. You really want to get your butt back, chest high, like almost like you're sitting in a chair. So if you're putting your body against the wall, you're actually gonna have really good form. And you have a little bit of support. Now if this is easy, you can hold it and do a wall sit. That'll make your quads burn. Or you can get one of those big stability balls and put it behind you. Don't fall. But you can kind of roll it up and down. And that just makes it a little tricky. But that's a really good one too. Another way, just holding onto a chair. And then just doing a mini squat, like so. Again, you don't want to do this. This is not, see that way too much. Not good for it. All right, moving on. Any questions? Core. Core and back. We're good. I like your style. Flip them over, we're done. Okay. So So I have 2 of my favorites on here. A lot of times when people think, oh, I need to strengthen my core, a lot of people come in and say, should I just do like 100 sit-ups? Well, if you're having back pain, think about your spine and what your spine's doing. You're doing a lot of flexion and extension over and over and over. Repetitive. If you have any sort of degenerative disc disease, stenosis, that's gonna be too hard on the back. So what I like, it's called Sarman lower abdominal progression. So basically what you do, it's easiest laying down on the floor. You can do it standing up, it's harder. But basically the principle is basically bringing your belly button in and contracting your abs. A lot of times people think, I'm like trying to show like a 6-pack. It's not that muscle, it's literally draw your belly button in. Sometimes if you do a Kegel, I don't know if you guys know Kegel, like as if you're going pee and where to stop, clenching those muscles will engage more core, and that really, really helps stabilization. Once you get that down, you can do it seated, you can do it standing, and then if you're laying down, I'll show you guys a little progression. If you're up here, keep your back nice and flat, tuck that belly button in. You can march, like so. If that's too hard, you can just kind of do one at a time. Keep that belly button tucked. You should be able to breathe, you should be able to talk. A lot of people hold their breath. You need oxygen. If you're really good, you can bring your feet away from your body, like so, or you can kind of do like a march, like so. And think about your spine. Your spine is neutral. You're not over here doing a ton of crunches and hurting your spine. So that's another one you can do. There's one more on the ground. Bridges, pretty common. Going up and down. Squeeze your bottom. This gets your glutes, your hamstrings, and your core. And if that's easy, you can add marching there too. Again, probably something you're not gonna do on the pickleball court, but I don't know. I don't know your style. Do you guys have cocktails? Maybe after a couple cocktails? I don't know, I haven't played yet. I gotta figure it out. Oh yeah, shoulder it is. 2 more. You guys are gonna have a lot of homework.
Yeah.
So I put on here 3 times a week. Every day is excessive. I like the stretches before you play, strengthening a few times a week. Okay. Okay, now that I've knocked this up. Okay, so next. So Dr. Motz was talking about rotator cuff tears. It's really, really important to strengthen your rotator cuff to prevent injury. So going in and out, this will get your internal rotators. A big mistake people make is, again, going in and then just letting it fall. You want really good control in, really good control out. Sometimes people use all of their wrist. Maybe their shoulder's weak and they compensate with their wrist. That'll be good for your forearm, but the goal is shoulder. And the reason why we're strengthening the rotator cuff, it's a stabilizer. Like Dr. Motz said, it's a small muscle. It helps keep that ball centered in the socket. A lot of people, again, think shoulder strengthening. Let's go to bench press. Let's do all these big, heavy weights. It's not about that. It's about getting the little guys. We don't want to tear the little guys. Okay, so that's internal rotation. For the right shoulder, just so I'm not having my back to you, external rotation is going outward. And again, slow motion out, slow motion in. You don't want to go out fast. You don't want to do that motion or twist your back. See some interesting things out there. So slow and controlled. And you can even keep your belly button tucked, get that core going too. Alrighty. Next, actually I'm going to skip one since we have the band one. I'll come back to that one, is pull downs. So, yeah. So there we go. You can put that in a doorway or have a nice little friend. I'm gonna rip your thumb off.
Yeah, that's hard as
So good posture. Keep your shoulder blades back. Try to bring your arms to the side. I'm not pulling so hard because I'm really afraid I'm gonna hurt his arm. But you get the point.
Not paying him enough.
I should have brought the yellow. Oh no, he hurt. Okay, serratus punches. So your serratus anterior muscles right around the shoulder here, help stabilize the shoulder. Really small muscles, so I'll demonstrate so you guys can see laying or standing up, typically laying on your back. Elbow stays straight, your shoulder goes forward and back. You can do both at the same time, but it's a really small motion. Turn this way, bring out and in. So only a couple inches of movement. I have 2 pounds. I would say start maybe 2 or 3 pounds and then work your way up. Sometimes people will lay down and shrug their shoulder to try to get their upper trap to help. You want to keep good posture even while laying down. Okay, last shoulder exercise. Flexion. So basically, good posture, belly button tucked, go to 90 and come back down. You want to go to about a 45-degree angle, and this will help strengthen your shoulders. Good.
If you're already having pain in your shoulder, I would do all of those others first and get strong with those before you do that one. Because that one, if your cuff is already inflamed, that one may be more inflamed.
Yeah, and if you are having pain, you can even go down to a 45. Like you don't have to go all the way to 90, you can maybe go to 45 or 60 degrees. Sometimes people will get the pain up here and I'll say, don't go that high. Yeah. Yes, all these strengthening exercises should not hurt. Last one. Guys still with me? Good. Guys are gonna be so good this year. You're gonna be so strong. Hit the ball further. All right. So next are wrist flexion curls and wrist extension curls, keeping the forearm strong to prevent any sort of golfer's or tennis elbow. So basically you can stand up with a table like this, you can sit down at a table like that, and you're just gonna slowly curl and go as far into the arc of motion as you can. So going all the way down, all the way up. So just a curl, nothing too fancy. So this goes into flexion, and this is an extension. And I would say about 2 sets of 10 should do the trick. 2 or 3 pounds, you don't have to do anything crazy heavy. Quality over quantity. Because if you get too crazy and be like, I'm gonna do 10 pounds twice a day, then you might see us with some tendonitis from overuse, so. All right, so I kind of narrowed it down to a bunch of different body parts. I had it separated with stretches. Question in the back.
Are these exercises meant to strengthen the tissue in the tendon, not just the muscle?
So your muscle's contractile tissue. Your muscle basically turns into a tendon that attaches to the bone. So the key is to strengthen the muscle.
So you're not, the tendon tissue does not actually get stronger. It can get more supple, but it doesn't get stronger physically?
Kind of. Yeah,
That's
see
right.
what I
You can't really strengthen the tendon.
Okay.
You can strengthen the muscle, but you can't really strengthen the tendon. But you want to get rid of the inflammation because that can weaken the tendon.
Right, yep.
So the second question
Yes.
related to that, are there supplements or foods that are, have the ability to strengthen your tendons?
Ooh, that's a really good question.
Vitamins.
So you don't have to exercise.
I mean, eating a healthy balanced diet of fruits and vegetables are always a good idea over processed foods and all of that. But I don't have any magic tricks on if you have spinach 5 times a day, you'll never ever have an Achilles rupture. I don't have anything quite like that, but obviously, like just having a healthy diet, drinking lots of water, staying hydrated is key. I don't know if you have.
That's right. There is no, unfortunately, there is no supplement that strengthens tendons.
Yeah. So, all right. Any other questions? Yes, in the back. Yeah.
I suppose this depends on the injury, but any guidance in terms of when to work through an injury and when to let it rest?
That's a good question. Kind of depends on what is going on, but that's probably going to be hard for you. Golfer's elbow. Yeah, I mean, I would start with stretching. Golfer's elbow, so that's basically irritation of the common flexor tendon. So I like this stretch a lot, getting your shoulder really strong. So if you have maybe a job or something you're doing that is basically repetitive flexion, it's going to irritate it. So basically getting the shoulder stronger will help to not do so much flexion. Sometimes even people will wear like a wrist guard. So throughout the day, they're not flexing the elbow and irritating it. So that could be a good place to start, icing it. But kind of like Dr. Motz said, if you have tendonitis and it keeps going and going and going, you can get to a bad place.
The other thing is both the tendons on the inside and the outside of your elbow are layered. Those tendons sit on top of each other. And sometimes what happens is you get that inflammation and they get sticky and start sticking to each other. So you start getting eccentric pulls against it and it just makes the tearing worse. So it seems kind of counterproductive because it hurts when you push on it, but doing some cross friction massage can really help tendonitis. So really just get your thumb right over the spot that hurts and rub it. And it feels like you're rubbing a bruise, but it really does help because you can free that tendon where it's getting sticky, you can free that up and keep it from becoming worse. And that sometimes will clear it up as fast as anything you can do.
Thank you.
I agree. And also I do dry needling. I don't know if you guys have ever had that or heard of that. I really like it for tennis elbow, golfer's elbow. Basically, you're putting needles in those tight muscles. It's like a trigger point release. And I've had really good results. So if you're willing to try different things, that's an option too. As fun as that sounds. Was there one here?
Yeah, one thing I didn't see in here is anything about core exercises like planks and so on.
Yeah, so I kind of had mentioned the belly button tucks. That's kind of an introductory one, the bridges, but planking I really like too. That's a little more advanced than what I showed you guys, and I like it. It keeps the spine nice and neutral. It's harder to do, and if you feel comfortable doing it and you can, that's an excellent exercise. It gets your back and it gets your shoulders too, so I love that too. Very good. Just hard. All right, what else, guys?
When you use heat and when you use ice.
Okay, I have a theory about this, so we'll see what you think. But so heat is a vasodilator. It brings blood to the area. So let's say you sprain your ankle and it is huge. You're not going to throw heat on there because that can make swelling worse. Now they're both analgesics. They're both good for pain. But ice is a vasoconstrictor. So if you have the ankle sprain, you're really swollen, that can help get the swelling down. So it's kind of tricky, like a tennis elbow thing. That one I think is a little bit trickier because you have inflammation, but it's also tight. Heat also helps if you have a tight muscle because it helps increase that blood flow. So sometimes maybe for a tendonitis, I'll say ice at the end of the day when it's irritated, but maybe if you're like first thing in the morning, if it's really tight, maybe put a little heat more in the muscle, not so much at the irritated spot. So it's not always cut and dry, but that's kind of my rule of thumb. I don't know if
Generally, right after an injury, ice is going to be the way to go. When you're trying to do some rehab, a lot of times the therapist will heat you up before they do stretches and things because heat does help relax those tissues when you do that. So on an acute injury, ice is almost always better in those first few days afterwards, and then it's probably some combination of the two from that point on.
yeah, good question.
When in doubt, I would say ice. If you're unsure, ice is probably safer than heat.
Great.
He feels
Yeah.
better. Yeah.
I have a question for Dr. Motz. My
It's
daughter.
Motz actually, but yeah,
Motz,
that's okay. That's all right.
Okay. Mozzarella? No, Motz.
That's what it is.
I
It's
know
the
like
things
that.
around castles, not the cheese.
That's awesome.
My daughter who's just turned 40, she's a Division I athlete. She's experiencing knee pain now. And she has just had the PNP,
PRP.
PRP. What do you think of that technique to?
Yes.
So PRP is platelet-rich plasma. So basically, they take some of your own blood, they spin it down, and they take the platelets and the plasma and then inject it into a tissue. And you can inject it into a joint, you can inject it into a tendon, which is really painful. But the idea is to try and stimulate healing. The plasma and the platelets have healing tissues in them so they can stimulate a healing response. Intra-articular injections of it, it's really a pretty mixed bag. There's not much research that shows that there's long-term benefit from that. And generally what I'll tell young 40-year-olds who are having knee pain, who haven't responded to steroids, they haven't responded to the visco supplementation, the hyaluronic acid, you're faced with, boy, I don't know what else to do but surgery, I tell them, try that and see if it helps you. The problem with it is steroids and the hyaluronic acid most of the time are covered by insurance. PRP is almost never covered by insurance, and it's usually at least $1,000 for every shot. So that's kind of for me, it's you can try it, but I don't have strong feelings that it's gonna make a big difference for you.
All right.
All
All right. Thank you so much for all the lot.
I have extra copies up here if need be for the.
If you have any
front
questions,
list.
maybe you can talk to them one-on-one. They'll stay for a little bit longer, but don't keep them out, but too late, okay?